The final a few minutes we have, we can talk a little bit about what the future holds. We've talked a lot about what's there, what's available, what's FDA approved, what there is not yet guideline approved, but probably should be. But what does the future hold for this field in terms of things like not just longer duration, but I'd love to hear your thoughts on even longer duration beyond what's labeled and approved right now. Does it need formal study? Are such studies underway? And then just potentially other approaches or agents, either drugs or maybe even if you're aware of devices. Well, what's going on?
One of the concepts that I already mentioned was this idea that patients are at risk for venous thromboembolism before they're admitted. And I think, potentially one of the future avenues for investigation may be prophylaxis pre-hospitalization in a patient that you think might ultimately end up needing to be hospitalized. So you might see a patient in primary care clinic that you're going to observe over the next couple of days and make a decision about admission or not. That might be a patient that in a trial, this needs to be studied and proven, but that might be a concept that we start to look at in the next few years.
So someone, for example, with a heart failure exacerbation, you're trying not to admit them, but you're diuresing them
Maybe
at
they're
home.
going to an advanced center or one of those centers where they're getting infusions
Sure,
of
a
IV
shot
diuretics.
of IV diuretic
Yeah.
once a day. Yeah, that's really a great idea for a trial. What other thoughts in terms of what's new or could be new or should be new?
Well, I think for taking what we know now and implementing, I'll address that first, and I think there's going to be a lot of ongoing trials. But so
Implementation
number
science.
one is risk assessment in all hospitalized patients. And I think what's happening or changing is payment models are starting to align with these things in terms of the way healthcare will be paid in the US, with more emphasis on population health and keeping them healthy. That fits with preventing events like VTE and other things after hospital discharge, where the hospital may pay a financial penalty. So I think risk assessment in everybody, select people for appropriate prophylaxis, both in hospital, appropriate duration prophylaxis, because hospital is only 3-4 days. You still need to give at least somewhere between 6 and 14 days as a minimum, because that's what the trials that showed benefit were based on. And then who might get 30 days, that's one thing. But I think this is going to move into, you have a patient who develops deep vein thrombosis or pulmonary embolism, survives that. Where the field is more moving to is a paradigm shift from what we used to do was treat people for 3 months and then say who needs to go longer and try and get them off anticoagulation because warfarin was so problematic and high risk of bleeding. This field's going to transition more to extended treatment or indefinite treatment will be the default for most people with an established VTE, and then you'll select who is it not safe to continue going forward. And the concepts of, we have different groups of people for risk of recurrence and so on. The risk of recurrence is sufficiently high in most people that, given our very low risk of major and fatal bleeding, we're going to be defaulting more to extended treatment for most people who develop VTE. And it really speaks to Mike, what he, as a cardiologist, was surprised about these rate of events at 3, 4, 5 years in patients with VTE. So in people who develop VTE, we're going to see more indefinite or life treatment with 10 milligrams of rivaroxaban or 2.5 milligrams of apixaban twice a day.
No, that's great. Any other sort of final thoughts, Mike?
Well, sadly, I think cardiovascular disease, including venous thrombosis, remains the biggest killer worldwide. 1 in 4 deaths are related to thrombotic disease of some type. And
that's a sobering statistic.
It is a sobering statistic.
Sure is.
The sad thing we've seen, though, is the pivot away from population health over to rare diseases. And we've seen a pivot away from investment in cardiovascular disease at a 20% rate down to 5 to 10%. And we've neglected population health. We've neglected cardiovascular disease. Part of it is because the cost of goods was so high in terms of trials. I think we're on the precipice of having digital health technologies like what we're doing in the, in one of the trials with the Apple Watch, where we'll randomize 180,000 people to watch, no watch. We're going to do it very inexpensively at 1% of the cost to do a randomized trial.
Yeah, that's amazing.
People will enter, they'll use an app to get consented. We'll cut out a lot of the bricks and mortar. We'll then look at outcomes. We're not going to have a clinical event committee looking at it. We're going to use claims databases. So my hope is that by enabling patients to engage in more trials at a fraction of the cost, we get more shots on goal in the cardiovascular space, get back in there, have a rebirth of cardiovascular research, and some of the things like factor 11 inhibitors. Well, here we've got a population that's at high risk of bleeding. And if we could lower that risk with like a factor 11 inhibitor, maybe one that's injected at discharge, you know, and assess it for 1% of the cost the way we used to, I think we can make a lot of progress.
Yeah, those were great approaches, and also you threw in there a great class of medicines that's being evaluated as an antithrombotic. Any other final closing thoughts?
Yeah, I think we are entering the era of the pragmatic clinical trial design. One of the things that has really impressed me, because I've worked now closely with our informatics department in the last 2 years, is the sophistication, growing sophistication of informatics to help us reach our goal. And I think some of the things that were echoed here was, you know, implementation, especially universalization at a systems level of all these processes, using things like electronic discharge alerts, using things like usability testing, so that make it easy for the clinicians and make it within their workflow, and make it so that it's automatized as much as it can, using logic and using part of their workflow that they don't miss a beat. So it makes their workflow easier, not harder. We are hoping to get actually a grant to conduct a 12,000 patient pragmatic trial using something called Smart on Fire technology, which essentially, if successful, we're able to universalize, for example, the Improve tool, and then make it accessible in any EHR environment. So make it EHR agnostic. So use a Smart on Fire version of the, say, the Improve tool as a clinical prediction tool, make it access the health informatic exchange environment, make it auto-populate, and then connect it to an order entry, so that it's all automated both at admission and then at discharge and maybe even post-discharge. And I do think, as a last point to what Greg said, there's data suggests that about 5 to 10% of patients with chronic medical illness may benefit from prolonged, I would have to say long-term primary prevention. We just have to get a better feel of who these patients are. And indeed, now that we have safer options, I think that's a great group to maybe think about for prolonged primary prevention. And I'm thinking of the elderly, nursing home patients, patients on long-term care facilities with chronic cardiopulmonary disease. That's a great group of patients. It's a pretty large denominator.
Yeah, that really is. Well, look, it's been a terrific discussion. It's been fun, it's been lively. Hopefully for our audience, it's also been educational. So on behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative. I certainly did. Thank you for those of you at home for joining.